Good afternoon, everyone. Thanks for joining us for the final installment in the Harris School of Public Policy's spring event series, Confronting COVID, Coronavirus in the Contexts of Conflict and Post-Conflict. This event was organized by the Pearson Institute for the Study and Resolution of Global Conflicts, and I'm your moderator, Camarena. I'm a postdoctoral researcher at the Harris School and an associate at the Pearson Institute. I study the political economy of migration and conflict, and I focus on the implications for international aid and development. I'm excited to introduce our panelists to you today for today's discussion. First off is Maurice Amollo. He is a peace-building expert with 20+ years of experience providing technical support, oversight, and management of development and conflict mitigation programs. In his current role as Senior Program Manager for Mercy Corps, he is leading a peace-building intervention in the Middle Belt of Nigeria. Mr. Amollo holds a master's degree in peace studies from the University of Notre Dame. Gyude Moore is a senior policy fellow at the Center for Global Development. In a previous role as Deputy Chief of Staff to Liberian President Ellen Johnson Sirleaf, he played a crucial role in supporting Liberia's response to the West African Ebola outbreak, and also shaping its post-Ebola outbreak. Mr. Moore holds a bachelor's degree in political science from Berea College and a master's degree in foreign service from Georgetown University. And finally, Dr. Zaher Sahloul is a pulmonary and critical care specialist in Chicago. He is the co-founder and president of MedGlobal, which is a medical response humanitarian organization that provides healthcare services to refugees, the displaced, and the most vulnerable in crisis areas. Dr. Sahloul holds a medical degree from the University of Damascus. There will be an opportunity to answer audience questions at the end of the discussion. Please use the Q&A feature to post your questions. So let's turn now to Mr. Amollo and thinking a little bit about peace building and coronavirus. So Mr. Amollo, with Mercy Corps, you manage a peace building intervention in the Middle Belt of Nigeria designed to mitigate conflict between farmers and pastoralists. Can you briefly describe for our audience the context of this conflict and the design of your program? In particular, what are the objectives and how does Mercy Corps measure the impact of this?
Thank you so much. Just to say that before I talk about this particular conflict, Nigeria in general, is a country that is facing multiple challenges, but with a lot of opportunities and potential. Currently, if you look at the fragility index, Nigeria is around 14th and 9th in Africa. So that means that with all these opportunities and possibilities, Nigeria is still a very, very fragile country. Now, with regard to the conflicts in the Middle Belt, there are several factors that come together that are driving these conflicts. We have the climate change, particularly in the Lake Chad Basin, that is causing desertification and pushing many populations from north downwards towards south into the Middle Belt, specifically the Fulani communities that actually occupy a large area of that particular area. So because of this movement in search of grass and pasture, they come into conflict with the farmers who are settled because they sometimes drive their animals into the farms that destroy so many crops. The other problem is that Nigeria's demographics are changing. It's a very young population. The population is growing so rapidly. I think approximately now the last population census was sometimes in 2016. Today, it's estimated that Nigeria's population is anything between 200 and 250 million people. So there is a lot of pressure, particularly in rural communities where majority are what I would call natural resource heavy, dependent heavy. So it makes it extremely difficult, and a lot of competition to get a hold of those minimal natural resources. But also land, land has become a very, very big issue. The other thing that is complicating the whole thing is religion. Religion is a very, very strong form of identity in Nigeria. It actually overcomes any other form of religion or another form of identity. And whenever there is a conflict anywhere, people tend to get back immediately into their religious background. But the problem is that politicians have already taken advantage of this very strong unit of identity, and they use it as a unit of mobilization to achieve their political goals or for violence, whichever way you may call it. So sometimes it's very, very easy to say, oh, this is a religious conflict between Muslims and Christians, but it is much wider and more complex than that, with so many underlying causes. And finally, we have a serious challenge with the governance, where the public and the government, the rulers, they have serious, issues around trust. The public does not trust the government. The government, the politicians do not deliver on their promises, and even particularly on issues around security, where we've had, crime levels rise completely to complicate the whole situation. So what is Mexico doing? Mexico has been working in Nigeria for a while now, since 2008. Apart from working on issues around humanitarian response, we are also working on long-term development to try and tackle some of the long-term, causes of these conflicts. One thing about the Middle Belt is that, for example, in the first half of 2018 alone, 1,300 people were killed in the Middle Belt between the farmers and pastoralists. That is like twice the number that were killed by Boko Haram in the Northeast for the whole year. But there is a lot of focus on Boko Haram and what is happening there. Yet this conflict is more vicious and damaging, both economically and to the sanctity and dignity of human life in that particular area. So Mexico is working, number one, to try and prevent these conflicts by making sure that we rebuild broken relationships, strengthen social cohesion in this particular area. We build large structures that can be able to respond to some of these conflicts, like the early warning, early response mechanism that brings several people, different actors together to be able to send information when tensions are rising. But we've also developed the capacity for different individuals to be able to respond to some of this conflict through negotiation and mediation, so that the violence is resolved peacefully. We are also working on what we call quick impact projects. These are supposed to respond to more the structural components of the violence by either creating employment opportunities for young people, or digging water holes for women who face this violence from time to time because of the distance. But also, just connecting young people and women to, employment opportunities with other development programs and the government. Yeah, thank you.
So I'm wondering how the pandemic has altered your ability to carry out these kinds of programs. Has it changed conflict dynamics, and has it, due to social distancing or closures, made it more difficult for Mercy Corps to carry out the peace building activities?
I mean, COVID-19 has definitely changed the way we are doing business here. And number one, it has completely slowed down everything that we are doing. One, because of course, there is a pandemic going on, everybody's giving health priority, but that does not mean that the violence has stopped. I think that has been the most, disheartening thing, that despite all the, social distancing, restrictions on travel and movement, we still have violence going on in these particular places. Unfortunately, we cannot go, or we cannot bring the community members that we've trained to mediate some of these, disagreements and make sure that they do not escalate into violence because of these restrictions in movement. But at the community level also, for pastoralists or herders who are supposed to be moving from one place to another, because of actually, the determination to make sure that the virus is not spread around, their movements have been stopped. And that is creating a lot of tension in places where they were, the virus found them. And it's not strange to find, people blaming them for spreading the virus, particularly the herders, and that one actually creating more tensions in places where you have a lot of concentration of farmers and herders, or where they live close by. The other thing is that some of the policies that the government has put in place have not been, conflict sensitive. I think it's been more of copy and paste. You know, this is what has worked in this particular place. We are putting it here also, but in total disregard to the complexities of the context and, you know, how people, you know, behave in those particular places, the nature and the quality of relationships. So that has only helped to actually, you know, heighten the tension in these particular places. All our, you know, peace building is about building relationships. It requires people to, you know, come together, sit together, talk about some of these things, interact. Continuously, we create spaces where people who have broken their relationships, want to rebuild it, or are in long-term relationships can continue to interact in a more intensive manner. That cannot be done with the pandemic. And so we are afraid that, you know, some of these steps that have been taken may actually be damaging to some of the efforts we had achieved so far before the pandemic hit the country. Thank you.
My next question for you, I want to also pose to Mr. Moore. The two of you, I think, may be able to weigh in on this a bit more, which is, given the current context and the current humanitarian response to international development models, are we really equipped to deal with things like humanitarian responses and development in the midst of COVID? Can these models respond to the coming economic and health crisis on top of the other initiatives that you are already building? So Mr. Amollo, and then I'd like to hear Mr. Moore's thoughts about this as well.
Yes, so we've had actually to make a lot of adjustments so that we have a certain level of interventions that go on despite the challenges that have come with the pandemic. For example, we've moved quite a number of programs to radio, where we still have, you know, what we call live radio call-ins. We have specialists who go to radio stations. They talk about some of these challenges to do with peace building, begin to look at COVID-19 as a common enemy that does not care about your religious background, your ethnic background, where you come from, black or white, and look at it as something that requires our energy, everyone, and hope that if we can tackle this together, we'll be able to see the strength that we have in unity rather than the minimal, you know, differences that tear us apart. So we've moved that to radio. We have actually also moved quite a number of programming to social media to target young people because they are also the implementers of violence. So keep them, you know, in touch to continue discussing some of these challenges. What is it that COVID can teach us? You know, if actually it's attacking everyone, perhaps the differences we've been talking about are not really, really important. So we've had very interesting discussions in radio callings, through the social media, but also through our SMS platform, you know, where we send bulk text messages to communities, but they're also in a position to respond to some of those messages. And very interesting discussions, and we hope that this particular opportunity that COVID-19 is creating, you know, where people are beginning to see things, you know, slightly differently, could be something that we might build on post-COVID-19.
Great. So that's interesting that this is an opportunity to bring people together because of a common effort. Mr. Moore, what do you think about this? Are humanitarian and development models that we have now suitable for COVID-19? And can we do development and humanitarian intervention on top of the COVID-19 crisis right now? Oh, Mr. Moore, you are on mute still.
I was muted. Yeah. Can you hear me now?
Yes, we can.
Yeah, I think it's significantly harder to do humanitarian work now. You have to remember that these are places where even in the best of times, it's not the easiest thing to do. You have issues with access. The infrastructure is not in place. You have issues with significant distrust between the people in the government, and I'm happy that Maurice mentioned that. You have issues with states that are significantly under-resourced and incapable of actually providing services even in the best of times. So when these situations get compounded by an outbreak of this kind, especially health and infectious disease outbreaks, it becomes significantly harder But the good thing is, I think humanitarian models have and humanitarian actors have had to adapt, and they've done that beautifully. So, for example, the second largest Ebola outbreak in history is the one that happened recently in the Democratic Republic of Congo. Now, most people who follow the DRC politics understand that this is one of the most um, unstable parts of the country, and it has a lot of minerals, and because of that, it has a lot of non-state actor groups that are militia groups that are active there. And on the eve of the outbreak, there was an election, and in that election, the people from that part of the country were not allowed to vote because supposedly there was an outbreak of Ebola. And so people felt like that the government had politicized the outbreak to be able to deny them their franchise. And because of that, it made it very difficult for people to accept the government coming in there to respond to an outbreak that was ongoing. And so one of the first, I guess, one of the first casualties of an outbreak like that is what fragment of trust is left between governments and people. But trust also becomes a very, very important asset if that trust exists. And so what we did for example, in Liberia, was in places where the government was not the most credible actor, there are other repositories of trust, right? There are religious leaders, there are traditional leaders. And so in the DRC, they worked with local leaders to be able to reach those people. And I think development models that adapt to, I mean, the best way forward is what development agencies try to do, right? Which is state-centric, work through the government, work through the government agencies. But in instances where the state is not the most, it's not the most credible actor, or the state is not the most appropriate actor, then it makes sense for them to be able to reach out to other repositories of trust.
So that's interesting that, you know, trust plays such a critical role in your experience with the Ebola outbreak. And I'm curious what you think some of the other lessons learned in Liberia with respect to the Ebola outbreak are that shed light on what we should be doing now with the current pandemic.
Sure. I think I will go back to the question of trust again. The trust issue back home was not a distrust of experts or expert opinion. It was a distrust of government officials and politicians who consistently underdevelop or do not deliver or do not deliver at all on the promises they made. And so over time, there is what I call a reflexive skepticism of anything that the government is saying, right? Here, I think there is a distrust of experts, that there is a distrust of a class of people supposedly above other people who are telling people what to do. And so so the trust issue is really, really important. And in a previous statement, I said that trust is not something you manufacture in the midst of a conflict or in the midst of a crisis. Trust is something you build over time. And so it's like trust is a form of social capital, and capital is accumulated over time and deployed when needed. And so in a crisis like this, you deploy something like trust. So again, I think what we learned that, you know, in some places, there are people that the population will listen to. Maybe we should go through these people to talk to them. I think that's one thing. The second thing is, I think for the last 100 years, maybe more, in response to infectious disease outbreaks, there's been 3 methods, right? The first one is just to be able to determine who's sick. And the way to do that is to test. And so up front, you know, I mean, when we first began to respond to the Ebola outbreak, it was taking us between 9 to 12 days to get results from tests. And it meant that if a person was already symptomatic, that person was then infecting their family who was taking care of them, and it helped spread disease. So over time, you began to see these clusters of infection. And in the northern part of the country, we saw that entire families were wiped out because of that. So the speed with which we can test and how widespread the testing is really, really important. It applies here just as it did in Liberia. The second thing is trace. I know I've been seeing here that, you know, states are hiring contact tracers. It's insane to think that we are this far into the outbreak and we're just now hiring contact tracers. The way it works, the second T is basically when you test people and you find that they're positive, then you find the people who've been in contact with them so that you do the third thing, which is the treatment. And treatment includes isolation. So you isolate the sick people from the general population, That way, the general population is able to continue to move forward. And then so I think those 3 T's still apply here, just as they apply to the outbreak in Liberia. Thank you.
Great, thank you. So now I want to move on to some questions to you, Dr. Sahloul, to speak a little bit more to the context that refugees are facing around the world. So your organization, Med Global, provides medical services to populations in refugee camps. And I was thinking of camps like those hosting the Rohingya refugees in Bangladesh, which are incredibly densely populated. So social distancing in that context may be impossible. And in fact, they lack basic infrastructure, and they're dealing with monsoons right now too. So I'm wondering, what are the unique risks that you see refugees in these camps face in the context of the COVID-19 pandemic?
Thank you, Kara. This is a very important question. And for us in the humanitarian community who are concerned about the displaced people and the refugees, this is compounded by the COVID pandemic right now. You know, as everyone knows, we are in the midst of a global refugee crisis. There are about 28 million refugees, more than any time since the Second World War, about 78 million displaced people. Among them, of course, one of the largest is the Rohingya refugees. Of course, Syrian refugees is another big group, and others. But the Rohingya refugees in particular are the victims of genocide. They fled in large numbers 2017 from their homeland in Myanmar to a small area in Bangladesh called Cox's Bazar. And in that area, there's already were 200,000 refugees, and then you added to them 750,000 refugees who fled in 2017. My organization, Med Global, have been providing healthcare in clinics in the largest camp in that area, Kutupalang Balokali camp, that hosts about 600,000 Rohingya refugees. A very dense area. The estimate is about 40,000 refugees per square kilometer, which is one of the densest areas in the world in terms of the number of people. So it's near impossible to have social distancing. Many of the tents, and I visited these tents myself in a medical mission, actually you go to the camp and there is an area on the top and you see around you seas of tents. And I entered the tents and you have 10 people, 15 people in each tent, very poor conditions. All of them are dependent on assistance. There is areas in the camp that you have mixing, no matter what you do at the time of food distribution, in the time of the bathroom, you have very high number ratio of refugees per bathroom. So it's impossible to enforce certain measures. Unfortunately, like other countries, Bangladesh, which is the host community, has been witnessing large number of COVID, about 35,000 so far, about 500 deaths. And since May 15, we started to hear about the first reported cases of Rohingya refugees with COVID-19. So that the first case was in May 15, and up to date, there's about 29 reported cases. According to many projection models, and the most famous is the Johns Hopkins prediction model, it's a matter of time before 90% of the camps become infected. So the estimate in the Johns Hopkins model that between 800,000 to 900,000 Rohingya refugees will get infected because, of course, of the density of the population in that small area and the impossibility of enforcing certain measures including social distancing and washing your hands with soap and water. Water is not very available. You have these pumps for waters, and it's difficult even to wash your hand and your body. The other problem that you're facing in this area, that if you have large number of sick people, especially who require hospitalization, the capacity of hospitalization in that area is very limited. About 300 hospital beds for 600 or 700,000 people. ICU beds is even more scarce. You know, in my hospital in Chicago, we have 250 ventilators, more than several countries that have large number of refugees, there's only 8 ICU beds in the Cox's Bazar area that can accommodate sick patients. 8. In my hospital, there's about 250 ICU beds in one hospital in Chicago. So you can look at the healthcare disparity here. Of course, national governments in many countries will give preference to their population when you have a crisis like COVID. And they will limit the access to healthcare to the refugees. Unfortunately, we've seen that in many countries, including the United States. So you will expect less services to the refugees. You will expect more restriction on movement. You can expect more restriction on information, which is very unfortunate because the Rohingya refugees are not only refugees and victims of genocide in very small area and have no access to healthcare, advanced healthcare, but also they do not have access to information that can help them dealing with this pandemic.
So I want to remind the audience that in a little bit we'll turn to Q&A. So please put your questions in on the Q&A feature. And while you're doing that, let me ask Dr. Sahloul one more question, which is to think a little bit about the Syrian crisis and the populations that Med Global helps there, and particularly how hospitals and other health facilities had been targeted as part of that war. So there's even less health infrastructure in Syria than there used to be. And how does Med Global respond to those kinds of problems as this pandemic emerges there as well?
This is a problem that we have faced in particular in Syria because there was systematic targeting of healthcare professionals, unfortunately by the government and also by its allies, Russia and other allies, who targeted hospitals because they wanted to deprive local communities from healthcare. And that led to huge displacement. So when we're talking in Syria, in the context of the Syrian civil war, of half of the population being displaced, about 6.5 million Syrian refugees, which is 1/4 of the total refugees in the world. One of the main reasons is targeting hospitals and healthcare providers. According to Physicians for Human Rights, more than 580 hospitals were bombed, mostly by the government. More than 925 doctors and nurses were killed, mostly by the government. And of course, because all of that, you will have shortage of healthcare providers, shortage of hospitals. That is very difficult to overcome. I wrote an article actually in Chicago Tribune a couple of weeks ago about the parallels between the Syrian crisis and the pandemic, COVID-19 pandemic in the United States. And there are many parallels. The lack of protection of healthcare providers is there. You know, in Syria, they wanted to be protected from bombs and from chemical weapons. Here, we wanted to have PPEs for protection. And we have doctors and nurses in the United States who died. The same thing in Italy and Spain and the UK and China. The mental health consequences of the crisis, because you're feeling as healthcare workers on the front line overwhelmed because of the scale of the crisis. This is another issue that we have dealt in Syria and we're dealing with in the United States. The fact that you cannot save every patient's life, and you have to select which patients you need to direct your energy and resources to.
Okay, so I have a question here from an audience member about people who are moving, not just because of conflict, but also because of economic trouble, poverty, loss of jobs, what have you. And how that context, and not just COVID-19, but other diseases that are perhaps preventable in the developing world, challenge this pandemic even more. So can you speak to people moving not just because of conflict, but other things, other reasons, and how that might challenge the efforts to contain COVID? So first, Dr. Sahloul, and then maybe Mr. Moore, you could comment on this as well.
I mean, we are seeing, and the world is witnessing more and more disasters, and this becomes part of our reality. So we have really to be prepared for dealing with disasters and making sure that our healthcare workers and people in general are more resilient, especially in low resources countries and developing countries and the countries that are prone to climate change. And you've mentioned the cyclones in Bangladesh. Just a couple of days ago, there was a cyclone Amphan that hit Bangladesh and India. If the cyclone hit the Rohingya community, that would be a huge disaster. When you have displacement of population related to limited resources, water shortage, climate change, wars and displacement, all of these things, that will lead to the same things. And people may associate disasters and war with injuries and death related to bombs and missiles, which happens. But actually, many people suffer from non-communicable diseases. When I mention Yemen, I think what comes to mind is malnutrition and cholera. Yes, that's a morbidity, but more people die because of chronic diseases like diabetes and hypertension and heart disease and cancer and chronic kidney disease and COPD, who are not getting treatment because they cannot afford to it, because of the shortage of hospitals that are destroyed, because of the shortage of specialists who can treat them, shortage of the surgeon who can perform even simple surgery. We had a medical mission in MediGlobal to Sierra Leone a couple of years ago, and we had people who have no access to surgeon who can do appendectomy because 1/3 of their healthcare provider died during the Ebola crisis. So these things are real. It is magnified when you have pandemics and disasters. We have to be aware of it, and we have to do something to reduce this healthcare disparity.
Mr. Moore, did you have some thoughts on both economic migrants, people moving, and also perhaps the additional pressure that the pandemics put on systems in post-conflict contexts?
Absolutely.
Thanks, Zaher, and thanks, Kara. Just to say, I think as Zaher has mentioned, particularly issues around climate change is really worsening the conflicts that we already have. I mean, climate change is a threat multiplier. And even in places where we already have other grievances, it is making things worse because, there are movement of people, as I said earlier, who are trying to look for opportunities. When these people move, they come with all their problems, including diseases. They're coming with all that. And it also puts a lot of pressure, of course, in the health systems of the countries that they are arriving at. That said, some of these challenges actually call for a more united, multi-pronged approach that cannot be dealt with within a particular specific country. I think like COVID-19 is really demonstrating to us is that some of the problems that we've seen happening in certain countries are actually problems that defy national boundaries and require a more united global approach to deal with them. So yes, any movement comes with its challenges. Economic migrations will still be there, and with economic migration, it will come with other challenges. Whether people are moving for good to do investment in other countries, or actually whether they are moving as economic migrants or they are being pushed by circumstances in their own countries, challenges with governance, persecution, it will still continue to happen. I think as human beings, we have this system of resilience that keeps pushing us to try and deal with the challenges that we are facing. And we not just sit there actually and say, okay, it has arrived, it will come and take me. So people will move and try to look for opportunities and try to look for areas where some of these challenges can be dealt with. And as long as that happens, there will also be health challenges coming with it. Thank you.
Mr. Moore, did you have some thoughts
Sure.
about?
I was just going to add, yeah, definitely. So my understanding, I mean, a lot of the people on this call are students at Harris School and students at the university who in a few years or in a few months are going to go out and be faced with these problems in real life and have to respond to them. What we're seeing is that humanitarian crises are becoming even more complex now because they're layered on top of each other. So for example, in East Africa right now, they have what is probably the largest outbreak of locusts in 70 years. And that is occurring at exactly the same time there's a significant stress due to drought. And then you have COVID-19. We have a huge number of young Africans who are trying to get to a better life, trying to cross the Sahara, trying to cross the Mediterranean. And what this tells us is that as these problems become more complex and become compounded, there's a certain amount of fatigue in donor communities, especially now in this outbreak where every single country is dealing with the pandemic. And because of that, it's harder for politicians to make the case to their public why they should continue to spend money elsewhere when they have these problems at home. Ultimately, it makes sense for us to be able to tackle these problems together. But I think it's important for us to think about what it would take to build resilience in places where these events occur and have a disproportionate effect, where people are more vulnerable. And so I think as a student of public policy, as a student who's thinking about large global problems and how to be able to solve them, how do we account for global public goods, it's important that students think not only of what we know and what we say, but that they be innovative. Like, we've seen significant innovation in almost every area but governance. And I think it's important for students of public policy to think about how we can be innovative in how governance is done that allows us to be able to tackle these problems more creatively than we've done, because the ways we've tackled these problems in the past are becoming harder and harder to continue, especially as these crises compound and overlay each other.
We have another question for you, Mr. Moore, which I'm going to read in its entirety for you because I think it will help. So it says, a tension that has evolved over the pandemic is local versus technocratic knowledge. So how were you able to balance this during the Ebola pandemic? And what are the lessons we may use here in the United States between states versus federal, or even within states and cities?
So quickly, just two things. I think one of the problems here in the U.S. that I've seen compared to what happened with us, first, it was a smaller country, right? With Liberia is about the size of, in terms of space, Tennessee, with like 5 million people. But first, there was a central plan. And in the U.S., what's missing is a federal central plan. The federal government has basically asked the states to do it. So you have 50 different plans. There's no way you respond to a public health crisis like that, where 50 different administrative units are doing something by themselves. And so that's part of the difficulty. The second thing is, I noticed here and in other places that it was the political leaders who were giving daily updates on the outbreak. We walked away from that. It was left to doctors and public health experts who were responding to the crisis to do the daily updates. And what that did was it depoliticized it. It took away the politics from it because the people who were responding were doctors. In some instances, if it were a doctor, they would wear their lab coat, and it conveyed a certain amount of authority. It conveyed a certain amount of subject knowledge and expertise. And so that's one of the ways we were able to do it. And I think it could be applied here too. The less people see, so if there were big political questions that needed to be tackled, then the politicians came in. But as long as it remained a public health issue, the people with authority to act and explain what the government were doing were public health experts.
We cannot hear you.
I'm sorry.
I think you are muted.
Can you hear me again now?
Yeah.
Yes. Okay, great. So there's another question here that kind of relates to the politics and connections to COVID-19. I mean, it's for Mr. Amollo particularly, and the question is wondering whether he thinks the pandemic can increase recruitment in the conflict, and when people are faced with their own mortality, is it more or less likely that they will join an insurgency, or does the realization of a weaker state because of a pandemic drive people to join conflict?
Yeah, so I think at the beginning of this pandemic, particularly when we had the index case in Nigeria, there were cases where particularly individuals from Boko Haram tried to twist the narrative and portray this as a problem of the West. or a punishment of people who do not respect the calling of God and the teachings. I think that went on for a while, but it didn't really gain traction. And so we were also worried that, through this type of narratives and propaganda, with time, there'll be a lot of anger towards the government, and it will create a fertile ground for recruitment into extremist ideologies. I wouldn't say that we have evidence that that is happening currently, because we haven't seen it. But that said, we also know that, the kind of particularly restrictions that have been put in place on movement, the lockdown, several major cities in Nigeria were in lockdown for a while. Right now it is been eased a bit. It has affected so many young people, employment, particularly those who are paid, wages on a daily basis. They have been out of jobs for a while. And so we anticipate that with time, and as COVID-19 slows down and perhaps a permanent solution is found to this, we are going to have a very large pool of young people without opportunities for employment, decent income, and that is going to create problems. Either, in a society where there is so much mistrust, and where a certain issue, an issue that is purely criminal, can quickly, gain an ethnic or religious, meaning. I think that will really worsen this situation. And in that, we think that most probably the Boko Harams of this world could take advantage of that to encourage, young people to join the group. But again, this is just anticipation. It's not something we can say for sure that we have seen. But definitely, I think when you say the weaknesses within the government, encourage recruitment, yeah, certainly. I mean, if for a government, if it's not in a position to provide services to its citizens, particularly, sources of income, security, very, very critical. And another person comes with a counter narrative, which in most cases would be propaganda, promises something better, they will take that and go if they can, be shown some respect where they are going, or imagine that they will get that respect. So all these are possibilities in post-COVID-19, and I think it's really important that as we deal with the pandemic right now, we also open our eyes to what this could mean after we've gotten a solution to this. Thank you.
You touched a little bit on sort of the economic implications for this, and we're seeing the economic downturn as a result of the coronavirus pandemic spread throughout the world, and so resources for humanitarian response are going to be more limited for the foreseeable future, and demands are going to be greater because every country is facing its own crisis right now, or many crises. So I'm curious from all of you, what you see as the most important goals with the more limited resources as we move forward.
Maybe I can start with, our experience at MedGlobal. What distinguishes MedGlobal than other NGO is the fact that we stress on partnering with local communities to build resilience within local communities. And I frankly believe, like many, that local communities in disaster areas are more capable to provide their own solutions than having us from the US or Europe imposing such solution. But what they need is empowerment. They need some support. They need some training. So some of the things that we have been doing, for example, in Yemen or in Bangladesh, is to helping the host community to deal with their crises by providing training in helping babies breathe, by providing technology that are cheap, adaptable, and easy to learn, like portable ultrasound. And many of the things that we can do can be done with limited resources, can be done through webinars online. You don't have to travel physically. There will be a lot of restriction on travel. And I think these are the things that most humanitarian organizations should be doing, and shifting the culture from sending medical missions to disaster regions where you have foreign physicians and nurses treating local population to empowering local communities and providing support to their local solutions. In Gaza Strip, for example, during the COVID-19 crisis now, local communities are producing PPEs. There are factories that are producing PPEs and disinfectants. So there is no reason to ship to them PPEs from China. You can just empower them to produce PPEs. The same thing in Rohingya population. You have women there who are producing masks, who are sewing masks. So you can support these kind of solutions. You have areas in Syria where they're producing very cheap ventilators because there's not enough ventilators. So empowering the local communities to provide solutions and innovation, I think would be the key in the next world, post-COVID-19 world, where you have travel restriction, you have less resources, and you have a lot of stigmatizations of certain populations, unfortunately, by governments. You talked about Boko Haram exploiting the situation. You have many politicians in the West who are exploiting the situations, including some in our countries, who are stigmatizing immigrants and refugees, and they will link them to disease and COVID-19 and other things. And that unfortunately will lead to policies that are more restrictive.
Yeah, I think that that you are right, that all sorts of political entities leverage these kinds of disasters to separate people and target people, right? And we see that happening throughout the globe. Mr. Amollo, did you have some thoughts on what you think the sort of most important goals are with limited resources and the travel restrictions too that Dr. Sahloul brought up? Mr. Amollo, I think you're muted.
Oh, thank you so much. I think, how do you prioritize this? Number one, I would say, what we are doing at Mexico, though, and I saw another question there talking about humanitarian agencies, leaving some countries and, to protect their employees. Yes, at Mexico, what we've done is that non-essential staff have been told to move back, but we are still providing those essential services. I mean, some of these challenges, some of the challenges we are dealing with are, honestly speaking, wicked. We can be very fashionable the way we talk about them and all that, but when you get in contact with them, it will take a lot of effort and time and coordination and efforts of everyone actually to begin to deal with them. And so, right now, of course, we have the COVID-19. That is a serious, serious issue that has to be prioritized. But we must also remember that there are people who have been displaced from their homes, whether they are refugees or internally displaced persons, who need medication on other diseases that are still existing. Other diseases is not going to leave because there is COVID-19. They're still there. People did not stop eating in camps because there is COVID-19. They still need food, they still need water, and more importantly, there are those who are in conflict areas who think that this is the best opportunity to really bring down the enemy, the so-called enemy. And so this building work must continue. And for me, I look at it in a more, I want to look at it in a broader sense. That I think as humanity, as development workers, as humanitarian response people, we have invested so much over the years. And if we think that now this is the right time to just take one and prioritize, all that investment could be wiped out like that. And we'll be back to square one. I think we'll find ourselves in a more worse situation. It should be a matter of actually sequencing rather than saying, oh, let's prioritize this over this. Let's look at what are those key things that must be done and what must go along with it, even as we deal with this particular pandemic. So I would not use the word prioritization, to be honest. Thank you.
Mr. Moore, so your thoughts on this? Maybe we don't prioritize. Dr. Sahloul's thoughts were that we need to transform what we do. How do we deal with the fact that we have fewer resources and more crises?
Yeah, so I thought I would, the dismal topic we're discussing to try to just see the possibility of opportunities here. One of the things that I've said about this disease is, in spite of all the difficulties that it has exposed, the vulnerabilities of our societies that it's exposed, it has also been an accelerant to trend. So one of the things that happened here in this country and happened everywhere in the world was most of the economy went online, right? And so it was a trend that was occurring already in terms of huge parts of the economy becoming digital. Across Africa, online platforms saw fourfold, some tenfold increase in terms of the activity, and that people within countries and on the continent were themselves trying suppliers where vendors were getting suppliers who were online and signing onto platforms and stuff like that. And we live on a continent that is very, very, in terms of infrastructure coverage, that is underserved. And so moving to digital parts of the economy has actually helped. So the hope, and another example I would give is during the Ebola outbreak, one of the problems we had was for episurveillance and people working in the rural areas who were doing surveillance on diseases, getting the information back to the central government was very difficult. And so this app was created, and as soon as they had cell phone coverage, they could be able to upload the information onto the app. So things that would have taken months to get back would actually take minutes to get back. So I think we can find ways that this disease has forced us to think about ways in which we can more cheaply provide the same kinds of services that we had provided before, but provide them in a way that is safe, provide them in a way that allows us to be able to do the exact same thing without reducing the quality of what we're doing, but significantly cheaper than we've done it. And so I think, you know, from the beginning, I was saying that for the last 100 years or so, we have the way of dealing with infectious disease outbreaks have been the same. One of the differences now is, you know, we have tech-enabled ways of being able to do it. So, for example, you know, Wuhan was able to test more than 9 million people in 10 days by pooling the test in terms of being able to do that, right? We have a contact tracing app that allows us, we have the use of digital information to show who's been in contact with whom. So we can find tech-enabled ways, we can find innovative ways to be able to provide the same services simply because now the resources we have are diminishing, the problems are growing.
So picking up on that and sort of the new opportunities with technology, I wanted to ask you to maybe be a little prescriptive, each of you, and suggest if we look to South America right now, we know that the pandemic is spreading through Brazil. There's a crisis in Venezuela that's being contained because of the closure of borders. Other countries in South America are struggling a lot more than they had in the past. So I'm wondering what you all may think to suggest we can learn from areas that have been more fragile persistently, like in Africa or the Middle East, and what is the advice we have for South Americans from a different regional perspective at this point?
Maybe I can try to address this issue. Ecuador is one of the countries that hit hard with the COVID-19, especially in some areas. And Brazil right now is the epicenter. But what they are in need, like what we need actually in the United States at the beginning of the COVID, were some direction, and I'm talking about healthcare workers here, on how to treat very sick patients who are admitted to the hospital. So training is very important. Training should be provided by, of course, local language, and it should be available online. And this is very easy to do. So how do we transfer them or share the knowledge that we accumulated in the United States in the last 2 months, 3 months of treating 1.6 million patients into training for doctors, for nurses, for administrators in Ecuador, in Brazil, in Chile, and Argentina and other places in Latin America, in a language that is, of course, they understand, in a way that it's make it easier for hospitals, for example, to address the surge capacity. So it's not only a training on medical issues and medical protocols, which is important for critical care specialists, for emergency room physicians, training on protection of nurses and doctors and respiratory therapists, and how to use proper PPEs, and how do you reuse your PPEs, training on the principles of dealing with limited resources, because we have limited resources in the United States. So if you have limited numbers of PPEs and ventilators, how can you manage that? How do you reuse? How do you adapt? How do you innovate? How do you reallocate? All of these important concepts can be provided digitally online for the local communities. And making sure that also that they have the proper technology that can be exported to treating these patients. And we're not talking about very expensive technology. Portable ultrasounds, for example, are very cheap, portable, small, adaptable, can be learned online. So these type of technology that are easy to use by local communities are also something that we can encourage to use.
Mr. Moore, Mr. Amollo, do you have thoughts on what we can take from the West African context and make suggestions either from the Ebola crisis or from the perspective of post-conflict or ongoing conflicts and how to deal with a pandemic?
Thanks, Cara. So I think if there is one key lesson that, at least for some of us, we've seen emerge, is just how critical good governance is in any country or any society. I mean, the spread of coronavirus in Africa has been slow, and there are so many theories around that. There are those who think that perhaps, perhaps Africa has already crossed the red line, or there are those who think that they are approaching the peak or whatever. But if you look at different countries and how the different governments responded to the pandemic, you see a big difference, both in the number of those infected, but also the number of deaths and those who are, getting out of it, who are getting ill out of it. So you can see that those countries that are doing well had very strong leadership. They took very decisive decisions. They rallied their people around a common cause. They built that trust, and people responded. Compared to places where you had serious cases, you have weaknesses within the governance system, things have not been as good. But even in some countries that might be described as middle income countries, they are doing very badly, and you can see that reflect on the capacity or the state of governance in those particular countries. But I also want us to come back. It also reminds me of our we've really praised our liberal economy and everything and all that, but perhaps it's also a problem. At this particular time when everybody is thinking about himself or herself, my country, so I've seen so many cottage industries emerge in Africa and begin to manufacture PPE materials, face masks and all this. Under normal circumstances, those things would have come from the West and flooded the market. And that young guy there who could have earned some income from making this thing would not get anything, because they would be produced cheaply somewhere and poured into the market. And then you'll be told, oh, they are not capable, they can't do this. No. It's because there is a lot of imbalance in the market, and they are completely incapable of doing anything. So the African countries are huge supermarkets. They're just selling. They can't produce, not because they cannot produce, because they cannot compete against, these heavily subsidized products from the West. So I think, that they are doing this, that young people have been able to come up with ventilators and face masks, and which are working just fine. Maybe we should start looking at our economic structure again. Thank you.
And Mr. Moore, I'll give you the last comment.
So quickly, yes. So first, I think what we learned, especially with responses in Africa to this, is that most places in Africa just use existing systems. So in places where they had an elaborate system in place for vaccinations, those systems were activated and co-opted to be able to respond to COVID. So instead of people starting from scratch and trying to rebuild entire systems, They were able to adapt systems they already had in place and institutions they already had in place to be able to do this. I think this is important. This is not the first pandemic and definitely not going to be the last. What we need to do is to build health systems that are resilient, health systems that can be adapted to whatever situation we're faced with. And the final thing I would say is to come back to the issue of trust. Trust is important to build long before the crisis occurs. And if there's anything that we've learned from our responses is that the social capital that our government has to spend and the compliance it gets from its people is a function of trust that exists between the people and the government. And that's not something you create in the course of a crisis. It's something that's built before then. So definitely adapting existing systems and building them to be resilient and deepening the trust between government and people.
Okay. And with that, we're out of time. So I'd like to thank the three of you for joining us and giving us your thoughts on conflict and post-conflict in the era of COVID. Thanks.
Thanks for having me.
Thank you.
Thank you.